We will first hear Dr. Neil Horn, who will speak in support of the motion as stated by Zawadi. We will then hear Professor Lukoye Atuoli, who will speak in opposition.
Oh. No.
The other way around. It's the other way around. Okay, so you have understood. We will then have Judy Kamau to speak after Professor Lukoye, and then Dr. Gitau will speak after that. We will not spend any time introducing any of the speakers for the simple reason that they are all well-known psychiatrists. And if you want to know a little bit more about them, you can Google them just by using their names. So to kick us off this debate, and I hope I'll get it wrong right this time, Neil goes first, or Lukoye, you go first. Yeah.
Thank you. Thank you. Thank you very much.
8:33. 8:33. Go on, Lukoye.
Yeah. Thank you very much, Frank. And without wasting much time, I'll just dive into the topic. I think to set the baseline, I would say that there are a few things that we all agree on, including those that oppose this motion. And the first thing that we agree on is that treatments for psychiatric disorders are old and in many cases outdated, and in many cases have a lot of problems that we all agree need to be sorted out. The second thing we all agree on, I hope, is that new treatments must be explored and new ways of understanding disease must be studied and new ways of thinking about illness must be adopted. Now, if indeed we all agree on these two basic principles, then this debate is moot because there will be no barriers. We will not have a situation where we say we shouldn't explore this or explore another treatment in an environment where existing treatments are woefully inadequate, old, and have a lot of problems associated with them. So having said that, then I think research on the use of cannabinoids and psychedelics must be supported as part of the effort to find these new treatments, to understand mental illnesses differently, and to eliminate the stigma that abounds around mental illness and its treatments. You will appreciate the stigma around this subject, for those of you in practice, that every other parent bringing in their young child with new onset psychosis will be blaming cannabis or some other psychoactive substance, even if the child has never ever used that substance. This is the degree of the stigma against these substances that we have. Psychiatry has a tragic history of psychiatrists acting beyond their level of knowledge and expertise and supporting harmful social interventions that have only benefited the political elite and given them the cloak of professionalism. Our predecessors labeled freedom fighters as being delusional, and they diagnosed political dissent as mental illness and advised mentors on the best psychological techniques to break dissidents and nonconformists. This is the history where we're coming from. And so as we make statements that are scientific or pseudoscientific about what we should and should not use, we must keep this history in mind. And I will now demonstrate the magnitude of our error in using research data that says unequivocally that we must investigate the use of cannabis and the use of psychedelics in the treatment of mental illnesses. As a baseline, I think we all agree that psychedelics are a group of psychoactive drugs that can induce hallucinations and feelings of euphoria by altering our perception, mood, and cognitive processes. The classic psychedelics, according to Yehuda and Lena, who published this in JAMA last year, classic psychedelics have rapid and profound effects on perception, cognition, and consciousness that result in part from the actions on the serotonin receptors. And this can result in heightened awareness of one's internal states and feelings of connectedness that can last several hours. And psychedelics can also induce challenging and difficult experiences and need to be used carefully and in the presence of facilitators and therapists who are trained to work with people experiencing non-ordinary states of consciousness. They offer unique possibilities in their ability to promote openness to engage with things that are often avoided and suppressed. In fact, before they were determined to be banned substances, if you like, psychedelics were used therapeutically to help patients open up and identify and discuss emotionally triggering material in psychotherapy. And in that same editorial, the two authors argue for the use of psychedelics to facilitate therapy by making it easier.
1 minute.
Okay, fine. I'll move on to cannabis as well. And the same situation in cannabis, that there is a body of work that has emerged that shows that cannabis, the two ingredients, tetrahydrocannabinol and cannabidiol, can be useful in certain states. So they have been found to be useful in improving anorexia, in dealing with seizures, in dealing with chronic pain, and in dealing with anxiety as well. And there's a huge body of evidence that is emerging on this. The sum total of all the current evidence is that there is still inadequate evidence because of the status of these substances being controlled or banned in many countries in the world, and that this needs to change in order to facilitate additional research that hopefully will yield new therapeutic agents and new targets for the treatments of a variety of mental disorders. And in conclusion, I would say I do not argue for recreational use of these substances. I argue for therapeutic use of these substances. And any arguments about the risks of use of these substances, for instance, on addiction, ignore the fact that there are way more addictive substances that are legal, that are being used non-therapeutically, such as caffeine, such as alcohol, such as tobacco, and that these substances actually do cause more physical, psychological, and social harm than psychedelics or cannabis, even when used recreationally. I beg to move.
Thank you, Lukoe. Dr. Neil Horn has a contrary view. Neil, you have 6 minutes starting now.
Thank you, and good morning to all our participants and viewers. I'm thrilled that we're talking about this because it's something that patients come to me on a very regular basis and ask questions about. And I think as a group of psychiatrists, we need to have the answers to those questions. But to turn to the debate, I think we need to clarify a couple of points as to exactly what we're debating. And I think we're having a debate about what this House agrees. And this House is a group of Kenya mental health practitioners. So we're not debating what people should do in other countries. It's important that we're clear on that. The second thing we need to be clear on is that we're debating the clinical use of psychedelics. So if we agree that psychedelics should be available for clinical use, that would mean that we have to agree who can use them and how they're used. Well, let's look around and see if there's anywhere where we can get some ideas from about how psychedelics should be clinically used, and ask ourselves the question, is there any country, including the most liberal, who are using psychedelic drugs clinically? Or are they restricted purely to research institutions? And my reading has revealed that in almost every country, they're not allowed at all. But there are very few countries where they have been allowed in research institutes, aside from two. One is Australia, where some psychiatrists have been able to acquire a special license with all sorts of terms and conditions to use these, but only in a strictly supervised and research context. And then there's the United States, where the 52 states can't agree on it. But some states have agreed that once the federal government or the FDA agrees these substances can be used, then they'll look into it. But there's one or two, namely Oregon and Colorado, where people are being trained to hand out magic mushrooms or psilocybin, and MDMA, which is also known as ecstasy, to patients in research studies and also in clinical practice. So what we're waiting for is exactly the point that the previous speaker made. We're waiting for some adequate evidence that these drugs are effective and safe. And as he's very kindly said, he's kind of taken away my argument from me. We don't have adequate evidence yet for the use of these drugs. So would it be wise for us as a group of mental health practitioners to go and say, we're going to be the world leaders in liberalizing our rules and handing out these drugs in Kenya? I think that would be a very ill-advised idea. But even if we as a group of psychiatrists did that, do we think that we'd be able to set up a regulatory framework to monitor this? I'd be very surprised. The next question we have to ask is, are these drugs even available? Can we go to a shop or a pharmacy and purchase a little bag of magic mushrooms, or a little bit of LSD, or a couple of MDMA tablets? Well, you can from your local drug dealer, that's for sure. Those drugs are widely available. The problem is, it would be very irresponsible for us to be distributing street drugs. So is there any pharmacy anywhere in the world that we can buy these drugs in from? I don't believe so. The manufacture and the distribution of these drugs still remains limited to research environments, and the technology required to bring that to Kenya, I think, is problematic. So I think, just to summarize, before I get the 1 minute warning, and I think I might even be within the 6 minutes, because there are only very few points to make on this. I think we should agree that with the psychedelics, and by psychedelics, I'm talking about magic mushrooms or psilocybin, MDMA or ecstasy, and LSD, all well-known party drugs. Are we agreeing that those drugs can be handed out by psychiatrists or psychologists and used in hospitals? I think we'd so seriously damage the reputation of mental health services.
Neil, 1 minute to go.
In this country. Thank you. We'd seriously damage the reputation of mental health services to do that in clinical use. Now, I suppose we should ask the question, what about research use? I don't think we're debating research use, so I don't think I'm going to engage in that particular debate, but I will agree with my previous speaker that we do have problems with existing treatments, and we do need to explore new treatments. We just have to be very careful how we do it, and we have to make sure that we're ready to use them when we think it's a good idea. Thank you.
Well, Neil, you have 30 seconds spare, which you can donate to Judy Kamau later. In the meantime, we must now move to Dr. Catherine Gitau, another psychiatrist. Catherine, you have the floor.
Thank you very much. I'm happy to be part of this debate, and I would like to just shift it a little bit and maybe discuss what I have used within my practice for just a year now, and that would be ketamine. Why? Because it can be considered in this class of other psychedelic substances. Ketamine has a lot of hope to many patients. In the sense that when a patient comes in with a treatment-resistant depression, having had a very poor functioning, a lot of disability as a result of the depression, then we're seeing that a relief in depression symptoms within 3 infusions of ketamine. And for me, I feel that this already shows that there is a role to play for psychedelic substances in clinical use. And this is not an experimental per se, it is a real life experience. Borrowing also from some of the studies that have been conducted, which has been that ketamine infusion in subanesthetic doses is giving relief of depression with effects lasting up to 3 to 7 days. And so that you're using maybe 3 to 4 infusions a week, we're seeing good response to treatment with patients having relief of depression symptoms. Now, suicide is another common presentation that we find in our facility, and patients coming in with attempts and with high intent for suicide, we find that they find relief of these symptoms once we start the use of ketamine, and knowing very well that ECT is an alternative for maybe patients who have suicidal behavior. There is a lot of resistance to receiving electroconvulsive therapy, but patients are very open to trying another form of treatment that would work faster than the normal routine antidepressants, and without having to use electroconvulsive therapy. So ketamine is offering a way out for patients who are very distressed psychologically and are about to take their own lives. And I have seen many patients respond quite well to ketamine infusions. Aside from that, we also have a difficult condition, or rather a condition I sometimes find difficult to treat, which is bipolar depression. When we put our patients on treatment, on the normal treatment where we are probably thinking of things like lamotrigine, lithium, or a combination of antidepressants and a mood stabilizer, it still will take about 3 to 6 weeks for a patient to find relief of symptoms. And when you offer them even 1 or 2 infusions of ketamine, you see a very quick response in terms of relief of the depression symptoms. And even if they had suicidal ideations, you find that by the time you're done with the 3rd infusion, the suicidal ideations are gone, and meaning that this person is able to go back to a normal state of functioning early enough without having to wait for 3 to 6 weeks, which is a great plus in terms of their quality of life. Aside from that, I have seen also in my practice where we are starting patients on antidepressants, and within the first few weeks of starting the treatment, even for patients who did not have suicidal ideations initially, find that they do develop suicidal ideations. And for those who did have suicidal ideations, they may become worse. So we're saying that the current—
1 minute, Daktari.
Yeah, well, thank you. We're saying that the current treatment definitely needs to be changed, and we need to be open to new types of treatments. And having seen that ketamine is effective, then we need to also consider other psychedelic or psychedelic substances.
Wow, we are really keeping time, and I have to thank you sincerely, Catherine Gitau, for you are describing your own clinical experiences. Judy Kamau, however, has a different opinion. Please share it with us now, Judy, starting now. You're muted, Judy, so you unmute yourself.
My apologies. Good morning, and thank you for this opportunity. I'm jumping in as an opposing and jumping in onto the negative effects of cannabis. which would support why we shouldn't use it in clinical practice at the moment in this debate. It does have its acute effects, which would include milder euphoria or relaxation or increased sociability, as my colleague has mentioned, which would put it out there as more of why it would be palatable to treat. However, it can come in with perceptual changes, depersonalization, panic, loss of time sense, high anxiety, tension, and confusion. In the developing brain, for an adolescent, it does have negative implications in academic functioning, social and occupational functioning that actually have been documented to extend later in life. And the disruption of brain development is not only related to, it can also be related to altering neurodevelopmental trajectories in life, and can cause a toxic effect on the brain, actually, as we've seen already from research studies that have come off. And the effect on the developing brains are also notable through soft drug exposure in utero, where children or those who have been exposed have worse measures in processing speed and memory, as documented a lot in research. Even for adults, marijuana has been found to decrease performance compared to controls in cognitive domains such as attention, memory, and processing speed, as well as psychomotor performance. And however, these neurocognitive disadvantages may persist beyond abstinence. So if you're considering it as a long-term effect, agent for treatment, those are things we may have to consider. And this might come, unfortunately, with some macrostructural brain alterations, changes in white matter, changes in gray matter, and also in neurovascular functioning. So we're also not forgetting there are other effects that have been notable with cannabis use anyway. It has also been linked causally as a direct cause for other psychiatric disorders. Here we're talking psychosis independently, initiation and exacerbation of conditions such as schizophrenia, a motivational syndrome, which especially after long-term use, and it can also have a dependence when we're talking about cannabis. My colleague earlier talked about jurisdictions and where it's allowed, where legal use is allowed of it. So when we jump onto countries where they've legalized use, it's interesting. They'll talk about medicinal uses for these conditions such as nausea, vomiting, advanced stages of cancer and HIV. But in these countries still, it is classified as a drug that has a high potential for abuse, and it's even still classified alongside other substances of abuse, such as heroin, LSD, ecstasy, even now. So if you're looking at it from a mental health perspective, then we'll wait and see. If they're already talking about legalization, then why aren't they also justifying it as being and lowering it in the profile of substances that have high dependence or abuse? Still in the same jurisdictions, the US FDA has not approved cannabis plant for any medical use. Neither has it approved it as for marketing application or to treatment for any disease at the moment. So my question to you is, now that a substance that already has documented and research supported profound negative effects on the brain and has a causal relationship with other mental disorders, should it be used to treat mental health conditions that in themselves come with a chronicity attached to them? So here we are talking long-term treatment. I think not.
Oh, thank you, Judith. All right, you have a minute to spare, which is a very good idea. Now, we will now proceed as follows. There are a number of people who will be encouraged to make comment if they are online, either because they expressed the wish to do so earlier, or because they have caught the attention, if not the affection of the chair. And I will call them out in no particular order. And then I will see if there are any other people who catch the attention of Zawadi. In about 10 minutes, we will have to hear the speakers again, making their concluding remarks. And at the very end of this presentation, we will take a poll to see whether this house supports this side or the other side. Do we have Dr. Siengo on this call? Dr. Siengo? No.
Hello?
Yes, Doctor.
Good morning.
You have a
Good morning.
minute. Go ahead. Go ahead. 1 minute.
This is an excellent debate. The organizers have done a great job. The speakers have done a great job. I think it's clear that we need more research to be able to decide whether it's helpful or not. But for now, we are not ready for it yet. Thank you.
Thank you, Dr. Siengo. Dr. Kemunto?
Doc,
Where do you stand in this debate?
I think for me, I will comment because we had a discussion with Lukoye because I came in late. But to say that there are a few things that are, we cannot lock ourselves out in terms of experimental and to find out what will work and what will not work, because I think there are some patients who have benefited from psychedelics. But again, with a lot of caution, because we are also seeing patients who are also developing addiction, as much as studies are showing that psychedelics are not addictive. I wish to have logged in earlier, but the login took me to my M-Pesa, so it has been a struggle. But I'm glad to be here anyway, even if it's at the end.
Thank you, Dr. Kemunto. I hope you've got enough money in your M-Pesa. Now,
I think I still have my balance.
No, it's perfect in order. If there's any other person who has a question, I think the function of putting up your hands is working. So you could put up your hand and Zawadi will bring you to my attention. Professor Madai? Muthoni?
Hello.
Go on, you have the floor.
Can I ask? I am not a doctor, I'm a psychologist.
Okay, that's not a problem.
But my concern is why the doctors are allowing legalization of alcohol and cigarettes. And they are also aware of all those people, that the drug dealers, what can be done so that these ones are also legalized. Because when we talk about the alcohol, it is poison. When we talk about cigarettes, they're even worse. When we talk about the securities, I am sure if they are willing, they're in a position to fight the drug dealers, because lives are really being destroyed, especially when we look at the young people.
Okay, I think that's a good question, and I think it's a question that we will address in a future debate. For now, sadly, we are restricted to conversation around cannabis and other psychoactive substances. Professor Madai? Muthoni? You have you in the house? No? David Bukusi? Bukusi not in the house, not a problem. I see a person called DC Ndiba. Your house, hand up.
Yes,
1 minute.
yes, I do.
Go ahead, Vanadiba.
So with the psychedelic substances, we can clearly see that there's some research that supports MDMA-assisted therapy for moderate to severe PTSD. And they were able to moderate the dosages and find a way for using this drug to suppress some of the functions of the amygdala, which really bring out the symptoms of PTSD, like basically being unable to be still, being restless, the intrusion. So there is a way for using these substances to sort of reduce the symptoms of mental illness as long as they're well regulated and have been tried and tested. Thank you.
You therefore support the use
Yes.
of these substances. Thank you very much. Do I see any other hand up? Put your hand down, Vanadiba. You've already made your point and made it very well. So somebody wants to say something, but they can't. And that's Budoni, Paul Esana. Professor Madai says she can't unmute herself, which is a great shame because it would really have been valuable to hear Professor Madai. When you're able to, just jump in. Does anybody else wish to make a comment at this point, either in support or against?
Hello.
Yeah, tell us your name, please.
Yes, my name is Dr. Teresia Njora.
Yes.
Yes, I came a bit late, and I wanted to know whether we can receive those recordings through our emails.
Yeah, that's a very good point. It will be shared with everybody who's registered. Do you have a question?
No.
On the debate, all right? Or comment on the debate, you're most welcome. No, clearly not.
So
anybody else?
This is Kemunto. I logged in with several laptops. I wanted to say that I've had an experience with CBD oil with several of my patients with anxiety. And while I'm not advocating for the use of the cannabis itself because it has so many other psychoactive substances, CBD oil, because it's an extract in itself, has shown a lot of benefit for patients with anxiety. And they actually showcase a lot of improvement in terms of their sleep patterns, in terms of depression. And I think for me, it is important for us to, the safetyness of use is what is important in terms of what we're going to prescribe for our patients. So I've seen a lot of benefits with it, but of course it was not approved. And some of the patients who actually brought in the CBD oil, I hope I'm not going to be prosecuted from South Africa. So yeah, so that is what I wanted to comment.
So Dr. Aito, is that snake oil you're proposing or what?
CBD oil.
CBD oil. Can you explain that to those who might not know what it is?
CBD is cannabinoid extract, which is an extract from the entire cannabis plant. Because we know that cannabis has about 140 or more psychoactive substances, that which has been labeled to cause psychosis and other aspects that we are not happy about. But CBD in itself has been shown to have a lot of improvement in terms of patients, in terms of relaxation, in terms of pain relief, anxiety relief, depression relief, and even improving your sleep patterns in terms of maintenance of sleep. But we do not have those extracts in Kenya because they have not been approved. But some countries like South Africa have the approvals for that extract itself that has been mixed in oil because of stabilization. So patients who actually just use the CBD extract in itself have been seen to have a lot of benefits. So if legalization would happen, it would mean that more legal ways of presentation of this kind of substances would be able to be achieved. But because we don't have that legalization, you find that everybody abuses the plant in itself that has all other 140 compounds. Thank you, Dr. Ray.
Right, so you speak in support of the motion. Thank you very much. Now, I think that brings us to the end of the general comments from the House. I will now ask for closing comments. And to be fair, The closing comment will be done in reverse order. So we will hear Dr. Kamau, Dr. Gitau, Dr. Horn, and finally, Professor Lukoye. So Judy, you have the floor. You have 4 minutes.
Mine will be brief. My first comment will be also be about the CBD oil that someone who was in favor of using psychedelics. Research has because of tolerance that develops with cannabinoids. Usually there's an eventual downregulation of the receptors. So which means that any benefit that you derive from the THC or the cannabinoid oil in regard to any mental health benefits actually would result in a symptoms exacerbation when you're not using it. So you kind of have to be under the influence most of the time for it to, and the longevity of it all hasn't been determined as such. Controls would still be a huge issue. We still have a long way to go in terms of finding or having, determining efficacy. And we already seen a surge in psychotic disorders already documented where there's legalization of all of this. So it comes in with a laissez-faire or an attitude about the safety of cannabis and other psychedelics because we don't have regulations and we're just jumping onto the positives. So again, I'm not against research, but as we stand now, we're still not in favor. We don't have enough to jump on to say we can continue, we can start using psychedelics in the treatment of mental health disorders. Thank you.
Thank you, Judy. You've done extremely well yet again. You have 1.5 minutes to spare, but that takes us to Catherine Gitau. You have 4 minutes starting now.
Okay. Again, I will speak on what I have been able to use, that is ketamine. And for me is to urge members to be in support of cannabinoid and psychedelic use of for clinical use, because already ketamine being within that class of other psychedelics has been proven to be very effective, and it is freely available. It is rather a cheap anesthetic drug, very available in very many facilities. So as mental health practitioners, if we were to promote the use in other facilities while monitoring the treatment carefully, then I believe we'll be able to help many Kenyans who are having treatment-resistant depression and really having poor functioning and poor quality of life. So it would be good for us as mental health practitioners to work together in terms of improving the quality of our patients' health by being open to other forms of treatment, not just sticking to what we have been using and not really benefiting some. So for me, I would urge people to support this motion and equally, practically, to support the use of other treatments in improving the quality of life of our patients. Thank you.
Thank you very much. We're doing extremely well, yet again. Neil, you have the floor, and you have 4 minutes.
Thank you. Thank you. And I think some really helpful points have been made by participants and speakers, and thank you for that. And I especially want to thank Dr. Gitau. I think we should have maybe clarified at the beginning of this conversation whether we were including ketamine in the debate, because it's a drug which many of us use on a regular basis. We've had many discussions in this and other forums about its clinical use, and it's widely recognized around many countries as a useful treatment, specifically for treatment-resistant depression and acute suicidality. So with respect to the title, I would like, if we can agree that we're not talking about ketamine here. I think almost all of us will agree that ketamine is a very helpful drug. It's not one of the classic psychedelic drugs that we sort of started debating. But people have also introduced the question of CBD oil. And to my knowledge, CBD oil, or CBD, one of the components of cannabis, is not a psychedelic. But I might ask Dr. Kamau to help me with that. Oh, it's too late. So I think valuable points have been made, and what I'd ask our audience to do is to keep focused on the specific topic of the discussion, which is that we are supporting the use of psychedelic substances. And I think that generally we understand that to include magic mushrooms, ecstasy, LSD. Those are the ones which are being used experimentally in other countries to treat mental health conditions. There has been some success, but the summary of the evidence is that there is inadequate evidence to recommend the use of these either in depression or PTSD or in addiction. Those are the experimental uses for these drugs. Now, the way that they're being used is in a very regulated research environment. They're not available for widespread clinical use. So I would urge you to vote against the motion, saying that we're ready for this in Kenya, to be bringing these drugs in and prescribing them.
Thank you very much, Neil. We're doing extremely well. Because people have been very conservative, very helpful in their time, Lukoy, you have your 4 minutes, and then we'll take a vote and other things like that. Lukoy?
Thank you very much. I will begin by very strongly disagreeing with Dr. Hon in trying to split hairs about the motion. Today's motion is that this House supports the use of cannabinoids and psychedelic substances for clinical use in mental health. Psychedelics include ketamine, include MDMA, include LSD, include all those substances that are classified as psychedelics. Cannabinoids include CBD and THC, which are the components that are the most studied components of cannabis that are used even in clinical settings. And so it is increasingly clear from the statements made even by those opposing the motion that they indeed support the use of cannabinoids and psychedelics, including ketamine and CBD for clinical use. And therefore, I mean, it seems obvious that the House must vote in support. I think when we talk about everything that has been said about these substances has been in regards to recreational use rather than clinical use. So for recreational use, there are dangers, there are harms, and they have been studied and so on. Because the substances being used are not refined, the substances used are not controlled, the doses are not well determined. But for clinical use, everything that is used for clinical use is used in a controlled environment, the dosages are determined, the patients are monitored, and outcomes are studied. And for that reason, then, everything that has been said against these substances is immaterial because it doesn't concern clinical use. It is clear to me we all support clinical use of these substances. When it comes to regulatory framework, it has been argued that regulatory frameworks in Kenya are weak, but we are using cytotoxic drugs in Kenya, drugs that kill people, and they are controlled by the same regulatory framework. How would this be difficult to control the use of psychedelics and cannabis in clinical settings? And finally, the potential for abuse in cannabis and the psychedelics compared against other substances that we use on a regular basis is exceedingly low. And this has been shown by research as well. I would argue that if we are going to schedule cannabis and psychedelics and say never ever use them for clinical use, then we should schedule alcohol, we should schedule caffeine, we should schedule sugar, and all other substances that have been shown to be a lot more addictive and a lot more harmful to individuals than psychedelics and cannabinoids. I beg the House to vote in support of this motion. Thank you very much.
Oh my goodness me, what a debate, as Jeff Konanga might say. What a night, what a morning. I think we've heard it all. We will now go to Zawadi, who will conduct the poll. We have already in the house, just on Zoom, almost 450 people. We have other people on our Facebook page. So this is a huge house. Zawadi, are you ready to take the vote? And then we'll make other general comments at the end of the vote. In fact, we'll probably ask the speakers in 1 minute to make a comment as to why they won or why they lost. Zawadi?
Okay, thank you very much, Dr. Njenga, as well as our panel. So we did not have a pre-debate poll because I was being very conservative with our time, but now we can actually vote on the motion. You will see a pop-up on your screen, and I'd like you to just vote either in support or...
Zawadi, please read the motion again.
So,
oh, it's there.
Yes, either in support of the use of cannabis and other psychoactive substances for clinical use in mental health. You can vote yes, no, or choose to refrain. And there's an poll also going on through the Facebook page. So feel free to do so.
Am I allowed to vote, Zawadi, or must I remain neutral?
No, you definitely
can't
must
vote.
remain neutral.
Thank you.
I note that there are two questions, the two polls with the same question.
Oh, goodness. Same question.
Oh, no, quite right, Prof. So shall we answer only the first question?
Yeah, we shall answer the first question.
Only the first question. Ignore the second question. Thank you.
Right, to answer the first question only, but it wouldn't allow me to submit. So it looks as if we have to answer both. But
Indeed,
it's the
you're
same
right
question.
again.
So maybe it's
Yes,
a quiz to check that you're doing it properly.
I think you
Yeah.
can,
Yeah, you can't answer just one. Zawadi?
Yeah, I'm also
She will
advised
just
to
divide the
say-
answers by 2.
Yeah,
It's fine, you can answer both and
Divide by 2.
then
yeah.
Thank you.
We can all refrain from the second question.
that's a brilliant idea.
if you refrain, you yeah,
Mm.
the others have already answered.
I promised you there'll be 1 or 2 technical issues, and this seems to be like the big one. Zawadi, how are you doing?
So far,
I think
doing
what
well.
Zawadi will do, when she's looking at the answers, she will only consider the first question and disregard the second. Yeah.
Zawadi, is that clear?
Yes, I am well advised.
Thank you.
Thank you.
Yeah. Ignore the second one. Whatever answer is given. Thank you. Right. Zawadi? And then we will give the speakers or any other person in the house the opportunity to make comment. Yeah, go ahead, Zawadi.
Just 1 minute, let me make sure that we are not leaving anyone behind. And so far, we only have 256 people having polled. So, but as it stands, the House has, does agree or does support the use of cannabis and other psychoactive substances for clinical use in mental health. Because
What are the numbers?
The yes have it at 66%, the no's at 28%, and those who chose to refrain stand at 7%. And these figures seem to be very constant. So I think the ones in support, the team in support, most probably, you know, yeah, the house that's
Right. Okay. Thank you very much, Zawadi. We will now accept comments. Half a minute comment from the house. Please remove this question, Zawadi, from the screen. Thank you. I don't see any hands up.
Hello.
Who is that?
Kamunde.
Sorry?
I am supporting that, but only in the hospitals for clinical use, not for social life.
Thank you very much. Any other comment? Before we come back
my
to
name
the
is
speakers.
Hanan.
Your name is
Hello?
Hanan, go ahead.
Yes.
Yes.
So I understand that Dr. Neil said that these substances have not yet been used clinically yet, and I understand that. But MDMA received breakthrough designation therapy for PTSD, and psilocybin was also FDA approved for treatment-resistant depression. And if it's FDA approved, that means that the drug is safe and effective for its intended use. So to me, when I did all my research on psychedelics, I realized that psychedelics are to psychiatry what penicillin was to medicine. Thank you.
Very, very brief comment. Any other closing comment before we get the final remarks from the four speakers? No, it looks like we must now ask for closing comments. Catherine, you have a minute.
As I have seen on the comments, it's time to think outside the box, and it's time for us to conduct our own research within our own settings, where we look at the effects of these other substances in clinical use, and of course, take care of our patients as we do so. So in the right forums, and use them appropriately, not misuse the substances. And I'm sure we'll have a great impact in terms of the mental health of our patients. So thank you very much for supporting this motion, and yeah, looking forward to implementation of the same. Thank you.
Thank you. Neil, you have a minute. Dr. Hon.
Thank you. I'm sorry, I couldn't hear the number of votes. What I heard was that the no vote was 68%. Can I have clarity on that?
Zawadi, repeat the results, please.
So the poll stood at the yeses at 67%.
The yes.
Yes. Yes is at 67, no has moved to 65%, no is 28, and those who refrained stand at 7.
So Neil, it looks like you will win another day, not today.
Well, I think I have to comment that a debate is a lot of fun, and it's a great sport. And
Yes.
I've enjoyed the discussion. I think the exciting thing is that we're having this discussion. But I must ask people to read the literature very carefully, because when we come on and we say that the FDA has approved this drug for clinical use, that's not exactly correct. So be careful when you go onto the internet and you read very many websites which might give slightly misleading information about what the status of these drugs is all around the world, because our patients will read and believe what they want to, and then they'll come and tell us all about it. So we really need to be familiar with the facts about these things. So I think everybody must do their own research and draw our own conclusions, because obviously a third of us don't agree while 2/3 do. Congratulations to the YES team. I think you argued well. It's been a great honor to be part of the debate.
Okay.
Thank you very much. And I think, as I said when I started, the debate is largely moot, in the sense that in a scientific environment, we will always be expected to push the boundaries and discover new ways of benefiting our patients. And if that being the case, then we cannot rule out the use of any class of medication that is potentially beneficial to our patients, simply on the grounds that we have social or moral or other fears about the use of that drug. Every medication is potentially dangerous, and every medication is only used on the balance of greater benefit than risk. And this too applies to cannabinoids, and it applies to psychedelics as well. Thank you very much. And I hope that we continue having these kinds of discussions. I agree with Dr. Horn that debates are exciting. They're nice ways of stimulating thought and getting us to read more widely and to use evidence in our clinical practice. Thank you.
Judy, you have the last word from the speaker side. Please don't show us your tears. You can
we also have to have an open mind that you can come from where from a very critical aspect to something that evolves into something that is very useful in treatment. So things change. Medicine is not static. Even when something sounds like it's the worst possible thing, so out there, if you mention to someone, we are using cannabis for treatment, prayers will be started. Open minds. Even malarial drugs was from a herb, and here we are. So
I thank you, Judy. Thank you so much. Catherine Kitau, Koya Tuli, Neil Horn, Judy Kamau, and everybody else who has been in this house. As I said earlier, there were 400 and almost 50 people on the Zoom call. I think that is testimony to the fact that we are on something interesting. We will put together another debate in the next quarter. For now, all that is left for me is to thank you and return you to Zawadi. Zawadi, any closing comment? No, we're having power fluctuations here, so Zawadi is probably gone away. So it's 9:30 in the morning, ladies and gentlemen. You go back to whatever you do on Thursday morning. Thank you very much for your participation, and congratulations to everybody who participated. Bye-bye and have a good day.
Thank you very much. Bye-bye.
Sure. Good morning. Fine, thank you. Welcome. Nikumbushe jina. Nani? Namba ya simu? Yes. Yes. ID number? Yes. Yes. Unaenda kumwona nani? Kama imeisha.